Hi, everyone. My name is Sarah Haroon. I'm an MCW Endocrinology Fellow, Year 1, and I'm presenting a case about a man with neck pain. A 37-year-old man presented with a 1-year history of neck pain and stiffness. He said he was unable to extend his neck to empty the soda can, and when he walked, he would see the sidewalk. A past medical history was remarkable only for substance abuse. He denied use of any prescription medications. Physical exam was notable for markedly reduced range of motion of the cervical spine. Hence, imaging was performed. This is a cervical spine extension view, and as you can see, it demonstrates diffuse osteosclerosis. There's decreased extension of the cervical spine. That's secondary to ossification of the interspinous ligaments, and also calcifications in the ligamentum flavum and the posterior longitudinal ligament, as shown by the double arrows. And these are narrowing the spinal canal. Cervical spine MRI was performed. T2 weighted image on the left and stir image on the right. It shows bone marrow signal in the cervical spine is substantially decreased in both images. And again, there are calcifications in the ligamentum flavum and the posterior longitudinal ligament, which narrow the spinal canal, as shown by the double arrows on the left. Subsequently, a full skeletal survey was obtained. This is a view of the pelvis, and as you can see again, there's diffuse osteosclerosis. These are images of the left forearm and the distal right leg and ankle. Again, we can see diffuse osteosclerosis. In the left forearm AP view, there's mineralization of the muscular attachments and the interosseous membrane, as shown by the black arrows. And in the distal right leg and ankle, there's an indolent periosteal reaction, as shown by the white arrows. The differential of osteosclerosis is quite broad, and I've divided some of the causes into genetic and acquired. Among the genetic causes are osteopetrosis, autosomal dominant, gain of function LRP5 mutation, carbonic anhydrase deficiency, and a group of disorders known as skeletal dysplasias. Among acquired causes are Hep C-associated osteosclerosis, fluoride toxicity, vitamin D toxicity, hypoparathyroidism, primary hyperparathyroidism, plasma cell dyscrasias, Paget's disease of bone, sclerotic metastases, mastocytosis, sickle cell disease, myelofibrosis, and renal osteodystrophy. Labs for this patient were notable for an elevated alkaline phosphatase of 302, normal range being between 40 and 100 units per liter, and a low 25 hydroxy vitamin D of 4.7, desirable value being between 30 to 60 nanograms per ml. Other lab workup including a CBC, calcium, phosphorus, creatinine, SGOT, SGPT, PTH, SPEP, vitamin A, hepatitis C antibody, and CPKBB were normal. The patient also admitted to marijuana use and huffing air dust cleaner, prompting a more specific workup for fluorosis. Plasma fluoride level was checked, which was 38.1, normal range being between 0 and 4 millimoles per liter, and urinary fluoride to creatinine ratio was 75.1, normal being between 0 and 3 milligrams per grams of creatinine. And this confirmed the diagnosis of skeletal fluorosis. Skeletal fluorosis has been described as endemic in India, Mexico, Australia, and parts of the Middle East, Africa, and Asia. It's often associated with consumption of high levels of fluoride in well water or teas and develops slowly over decades. It's rare in non-endemic regions, including North America and Europe. When it has been seen, it's been associated with massive tea consumption, especially powdered iced tea, swallowing of fluoride in dental products, industrial exposure, voriconazole use, and inhalant abuse because it includes difluoroethane. The typical presenting symptoms of skeletal pain, joint and cervical spine stiffness are nonspecific and will not prompt a workup for fluorosis in non-endemic regions. The first clue is diffuse osteosclerosis on imaging, which has a broad differential diagnosis. But additional findings of periostitis and ligament calcifications make skeletal fluorosis likely. Inhalant abuse or huffing is widespread in the United States, with more than 21 million Americans reporting engagement in huffing at least once in their lives. Huffing typically consists of abuse of aerosol inhalants, as these products are often able to produce or enhance euphoric effects from other substances, such as marijuana, which is what our patient was attempting as well. The effect of fluoride on bone depends on the amount ingested and duration of exposure. At low doses, the effect is actually known to be therapeutic for osteoporosis. However, as in this case, rapid onset skeletal fluorosis can occur in the context of inhalant abuse. So in skeletal fluorosis, the lab findings are often normal, including serum calcium, phosphate, parathyroid hormone, and vitamin D levels. Alkaline phosphatase and osteocalcin are often elevated. An elevated plasma fluoride level or elevated urine fluoride to creatinine ratio is diagnostic. There is no medical treatment other than removing the source and managing symptoms. Osteoplasty has been performed to treat ankylosis of the joints in the appendicular skeleton, and spinal decompression has been performed to relieve nerve compression. In the end, the take-home message would be that although differential of diffuse osteosclerosis is broad, further radiographic findings of periostitis and ligament calcifications make skeletal fluorosis more likely, and that there should be consideration of inhalant abuse in non-endemic regions. Thank you.
Excellent case, nicely presented, thank you. I do have one comment, very cool case, great presentation. We do have a few minutes for discussion or questions if anybody has either.
Dan Malone here. I've seen a couple of these cases when I was at UW, and all of them really had an inflammatory illness. So their SED rates were sky high, and they hurt all over. They were having a lot of discomfort. And in one case, it was from the antifungal, and I can't remember what the cause of the other one was, but it's an interesting entity. Good case.
Thank you.
Yeah, this is Neil Binkley. Karen Hansen and I have a fairly similar case, and she also, along the lines of what Dan Malone said, has multiple aches and pains. And she's also sustained just a multitude of long bone fractures. And I share your comment that there's no medical therapy, but it's incredibly frustrating. You know, the skeletal residence of fluoride is going to be years. I'd be interested to hear if anybody has any suggestions as to how to manage, or if it's even possible to think about managing the bone disease in people with a skeleton full of fluoride.
Hi, this is Joe. I was checking to see if Rob Wormers was still on, because he has some experience. In fact, he described the fluoroconazole thing, and is also, I think, published about tea. But I think he might have had to go. I couldn't find anything on how to get it out of the skeleton, and this young man missed his follow-up appointment just recently, which of course worries me.
And there was a question of what happened with his neck pain, if you know that.
It was, no, I mean, I saw him a few months ago, maybe I'm thinking June or July. And, you know, there's no way, even if he had stopped completely then, that you'd see much of a change this soon. And he failed his appointment. So I can't say, I don't know. I think, like Neil said, I mean, I couldn't find anything in the literature about getting it out.
What do
Anyone
you think,
else?
Neil and Joe, what do you think about trying to drive his bone turnover up with an anabolic and of course remove the fluoride to see if that might work? I mean, ethically you couldn't do that, but just as I think about it, that thought occurred to me.
Other people have talked about that. To Dan, one concern is these people get kidney stones. And the concern is that it might increase that risk. But but it certainly it's out there. People talk about it. I don't know of any. I didn't see any publications of actually doing it. And Sarah, did you come across any?
I think she's
I,
muted.
I didn't come across any. I read one case report where it took a decade for the BMD of a patient to improve, and his arthralgias improved in 2 years. So it definitely takes a lot of time.
You'd have to do that in an animal model before you could do it on a patient ethically. In other words, see if an animal model of fluorosis, you could drive the bone turnover up and maybe accelerate the fluoride loss, but you couldn't just go ahead and do that with a person.
Okay, excellent discussion. Those are all the questions we have.